I'm Dr. Radha and I'm here to discuss on why, when, how, what and how much of feeding for hospitalized patients. Why do we initiate nutrition support? The right nutrition delivered at the right time in the right dose can profoundly affect metabolic and immune responses to surgery, illness or injury. Owing to the benefits, nutrition therapy has emerged as primary therapeutic intervention. The benefits from nutrition therapy depends on disease severity, baseline nutritional status and nutrition regime itself, the timing, route of enteral axis, gut function, content of the feed and the patient tolerance are all important variables to keep in mind while planning and feeding a patient. Dietitians do nutritional screening and assessments as well as provide supplementary nutrition through oral, enteral and parenteral routes. All hospitals should therefore have qualified dietitians for patient care. The next question is when to initiate enteral feeding or enteral nutrition. To best combat malnutrition, begin nutrition support as soon as clinically possible. Historically, patients following elective gastrointestinal surgeries were kept starved or nil per oral until flatus. This is no more practiced as evidence overwhelmingly supports the safety and benefits of early feeding. Furthermore, enteral feeding lessens hospital length of stay, readmission rates and rates of complications even in critically ill patients. Thus, early within 24 to 48 hours after admission to the hospital, enteral nutrition is recommended for patients who are hemodynamically stable. Multiple meta-analyses show that this early feeding reduces mortality, infections and the length of stay in the hospital and ICU. Although underfeeding can occur via the enteral route, it scores over parenteral nutrition as enteral nutrition helps in maintaining gut integrity, supports healthy gut bacteria, reduces the gut or the lung access to inflammation, sustains the mass of gut associated and mucosal associated lymphoid tissue and reduces systemic inflammation. In patients who do not tolerate enteral feeds and are at risk for malnutrition, parenteral nutrition may be necessary if nutritional support over 7 days is anticipated. For otherwise well-nourished patients, the EPINAC trial supports initiation of parenteral nutrition after 7 days in those who fail enteral nutrition. In malnourished patients, initiating parenteral nutrition as soon as possible will reduce complications, mortality with trophic feeding done to maintain gut integrity. There are some patients at high risk for malnutrition who require early feeding, those with organ failure, pulmonary, renal or liver, acute pancreatitis, post-major surgeries, open abdomens and burns, sepsis, chronically critically ill and critically ill obese and who are on vasopressors. They need tailored nutrition to prevent malnutrition. The third question is how to initiate feeding. Choosing an appropriate route of feeding is vital in patients who can safely tolerate oral feeds. This is always the preferred route. In others, nasogastric or nasoduodenal feeding tubes may be necessary for enteral feeding. When enteral feeding is contraindicated, parenteral nutrition becomes necessary. And after that, the question is what to initiate once you've decided which nutritional routes. One can blenderize meals into a liquid for tube feeding, but this can risk microbial contamination, inconsistency in supply of nutrients varying from 16 to 15%, and higher osmolarity and viscosity, and possibility of blockage of the feeding tube. Therefore, blenderized kitchen feeds are not appropriate for use in hospitalized patients. Scientific formula feeds for enteral nutrition include those for oral feeding and those for tube administration. FSSAI, the regulatory organization in India, grants stamping for two main categories of scientific products. The first, FSDU, foods for special dietary use, and second, FSMP, foods for special medical purposes. These foods are specially formulated and intended for feeding hospitalized patients. Food products with high degree of supporting research are classified as FSMP, food for special medical purpose. The wide range of enteral feeds allow us to choose the most appropriate formula for a patient. Standard, energy and high energy, adult or pediatric, polymeric, oligomeric and monomeric formulas, standard or disease-specific formulas can be chosen. Similarly, parenteral nutrition can be started with ready-to-use bags that provide macronutrients like protein and energy, and micronutrients like electrolytes, trace elements, vitamins together with water. Solutions of crystalline amino acids are used as a protein source during parenteral nutrition. Parenteral nutrition can be provided with a central line or a peripheral line depending on the predicted duration of parenteral nutrition needed. Glucose is the only carbohydrate that is used in parenteral nutrition nowadays, while there is a wide selection of lipid emulsions including alone or in combination LCTs, long chain triglycerides, emulsions, MCTs, medium chain triglyceride, olive oil and fish oils. The next question arises is how much to initiate nutrition support. Although rapid achievement of feed goal is ideal, the Eden trial failed to identify any benefit with full feeding over trophic feeding of about 400 kilocalories per day in patients with acute lung injury. This result is likely due to an increased endogenous generation of glucose during the first week of critical illness. To decrease the rate of underfeeding, it's better to use a daily volume-based goal like the PEPA protocol over daily calorie or rate-based goal. The best way to combat malnutrition is early feeding of at-risk patients via enteral routes. When underfeeding via the enteral route occurs, it is better to shift from rate-based to volume-based feeding targets. overfeeding and underfeeding, whether enteral or parenteral, are both linked to worse clinical outcomes. As with everything else in patient care, balance is the key to effective nutrition. Thank you.